Is my screen visible?
Yes, sir.
So ventilator associated, it is one of the, is it an acquired condition or a innate condition?
Acquired, sir.
It is a hospital acquired infection. Okay. So that is
Yes,
also
sir.
one of the things that has to be included in the answer. Only patients
Yes,
who
sir.
are
Okay, sir.
intubated and ventilated, they develop this particular problem. So it occurs in
Yes, sir.
patients who have been on mechanical ventilation for more than 48 hours. It is the most common hospital acquired infection. Okay?
Yes, sir.
What are the other types of pneumonia you know of other than this ventilator associated pneumonia?
Community acquired pneumonia.
Very good. Yes, community acquired
Hospital.
pneumonia. Then anything else? These are the two things. Community acquired, hospital acquired. Under hospital acquired, you can say ventilator associated. Okay.
Yes, sir.
So this is a clinical sign of purulent tracheal discharge, fever, respiratory distress, and when you do a culture, you will see microorganisms and also white blood cells in the tracheal aspirate, along with radiological evidence of pneumonia. Okay, that is the picture of ventilator associated pneumonia. The mechanism, presence of an endotracheal tube, is a significant risk factor because it breaches the natural protective barrier of the upper airway. What are the natural protective barriers of the upper airway? Whenever you get some secretion in the throat or in the upper airway, what will happen?
Cough.
Yeah, you try to cough it out, isn't it? But in the
Yes, sir.
presence of endotracheal tube, can you cough out?
No, sir.
No. And on top of it, when a patient is on mechanical ventilation, to prevent him from fighting and coughing, what do you do?
RV or sub.
See,
We
when
can
a patient is going on
suction.
bucking with the endotracheal
Suction.
tube, won't you paralyze and sedate the patient if he
Yes,
is not
sir. Yes,
tolerating
sir.
the... So that is another
Yes, sir.
hindrance. Patient cannot clear the secretions. So the paralysis and sedation. That is why we go for intervals in stopping the sedation. We try to see whether patient can tolerate the ventilation without any sedation and gradually reduce the paralysis also so that the secretions can be easily cleared. And so this earlier we used to have the culprit of the endotracheal tube. Is it the entire endotracheal tube which is a culprit or it is the cuff which is the culprit?
Sir.
What was the change that was done in the tube cuff from the earlier days when it was introduced? What was that was used in the long period when red rubber tubes were being used instead of the polyvinyl tube, which disposable tube which we are using nowadays? Earlier days when we were postgraduates, we used to use only reusable red rubber cuffed endotracheal tubes. Have you seen any one of them?
Not
You
seen,
had a
no.
chance to see the pictures at least? You have seen pictures, very good. So what is the nature of that cuff? Is it a low volume, high pressure cuff or a high volume, low pressure cuff? It is a low, high pressure cuff. The pressure used to be more than the capillary pressure, okay, of the mucosa of the lining of the trachea. So it used to be more than 20 millimeters of mercury. So prolonged ventilation with those tubes invariably caused compression of the capillaries, necrosis, and ulceration, and healing by fibrosis causing tracheal stenosis. Tracheal stenosis was one of the common complications of the yesteryears when patients are ventilated for more than a week with the tube. So to prevent that, they changed the cuff into high volume, low pressure cuff. When you say high volume, how much volume you can put in there? Normally, how do you say that the volume that you have put in a current present day endotracheal tube, disposable tube you are using, how do you assess that the volume that you have put in using a syringe, volume of air that you have put in is sufficient? What are the criteria by which you assess the inflation of the high volume cuffs nowadays, which are used for intubation? It's one of the practical things what you do every day in your OT. Whenever you give GA, do you check the cuff pressure or not in your OTs? Have you seen a cuff pressure monitor?
Yes, sir.
Yes, sir. Yes, sir.
So as soon as you inflate the cuff, you have to measure the pressure in that. What should be the normal pressure, accepted pressure?
25 to 30
15 to 20 millimeters of mercury, because that is the pressure of the capillary. So if you exceed that, the capillary will get compressed and there will be no blood flow. So that is why we use the cuff pressure monitor. And when you use that, it will have a range. It will be the dial will have a green bar between 10 and 30, so that you can keep the pressure between that safe range. If it exceeds 30, it will go to a red marking in the dial. And if it is less than that, it will be black. So tomorrow go and check your cuff pressure monitor. What are the things that are there in that? And how does the micro aspiration happen when you put in a high volume, low pressure cuff? How does this micro aspiration, which has to be prevented, which is the main cause for the development of ventilator associated pneumonia, happen? Have you ever watched or looked at the endotracheal tube after you remove it after a period of ventilation in a patient? The cuff portion?
Yes, sir.
Yes,
So
sir.
the cuff
Yes,
will
sir.
have
Yes, sir.
more secretions will be there.
the foldings will be there.
Secretions will be
Through
there.
those
What will be
foldings
the
and
appearance of the cuff?
Many fold.
There
It
will be
have
multiple
many
folds. Okay?
Fold.
Yes,
Yes,
So
sir.
these miniature folds develop because of the body heat. The cuff, which is made up of this polyvinyl chloride material, it reacts and forms small folds, and that small folds act like a channel, and through that only the secretions which are collected above the cuff, they slowly drain and go downward. Okay, so that is the importance of this micro aspiration, which is the main cause for that. And the mechanism include pool secretion, loss of cuff pressure, or the ET tube movement. Whenever the patient turns the head or you try to nurse him, take care of the back, and all those things, there will be slight movement of the ET tube, despite the fact that you have fixed it at the cheek with a micropore tape or a elastoplast. So the reasons for the irritation to happen are these three things. And the sources of these secretions are the oropharynx, nasal sinuses, and sometimes stomach. There will be slight silent regurgitation happening from the stomach in these patients. So the potential reservoirs of pool secretions are these three things: normal oropharyngeal secretion, sinuses drain into the oropharynx, and there will be slight regurgitation, silent regurgitation from the stomach also. And the susceptible leaking below the cuff, resulting in silent microaspiration. This word has to be repeatedly written in the answer if you are describing ventilator associated pneumonia, silent microaspiration. And the ET tube also causes epithelial damage, which impedes cough following mucociliary clearance mechanism. This is another important change that happens. Normal mucociliary clearance, where the cilia have a movement towards from the distal to the proximal. They try to push the secretions from the lower respiratory tract towards the carina, so that Once the cranial stimulation happens, patient will automatically develop a cough. That is the normal mechanism of the mucociliary clearance. And if your air that you are pumping or the oxygen that you are giving through the ventilator is a dry one without humidification, that will also hinder the mucociliary clearance, because the ciliary activity will be affected with the dry air inhalation after a particular time. And that is the importance of humidification of our inhaled gases, which is normally done by our nasal mucosa. And once you intubate or do a tracheostomy, you bypass this nasal mucosal humidification. So that is the reason why any patient who is mechanically ventilated should have a well humidified supply of oxygen or air, so that the mucociliary escalator, it is called, is well maintained. And these mechanisms compounded by ICU therapies like sedation, paralysis, positive pressure ventilation, and influence of gravity by the even though we recommend semi-recommend position, this will help the secretions to travel downwards towards the alveoli. And usually which part of the lung will be affected when they develop a ventilator associated pneumonia? Which lobe?
Lower lobe, sir.
Lower lobe. Why so much of hesitation? Naturally, it will go to the lower lobe, because that is the most dependent lobe, isn't it? So that will be the first one to get affected. And these ICU therapies also cause muscle weakness and then mucociliary dysfunction, reduced airway humidification, which exacerbate the cough, and tracheal muscle velocity and secretions get retained. Okay, so these are all the things that are basically important for the occurrence of ventilator-associated pneumonia. Sedation and paralysis, positive pressure ventilation, semi-recommend positioning, these things cause this problem. And this is second important thing is the bacterial biofilm formation. This is called the found on the endotracheal tube surface of 95% of the mechanically ventilated patients. So the biofilms act as a reservoir for infective microorganisms, and these microorganisms get dislodged and they enter the distal airway, which subsequently lead to the ventilator associated pneumonia. And associations found between pathogens in the tracheal secretions and the ETT biofilm are more or less similar. So even though we have organisms present in our oropharyngeal and upper respiratory tracts constantly, like the normal common salts that we have in the intestinal tract. You can compare our intestinal tract with the respiratory tract. We have normally some common salts present in the intestine. But when the number of these common salts increases abnormally, or your innate ability to protect yourself, the resistance goes down, these common salts themselves, they become pathological. Similarly, in the airway, what normal common salts are the bacteria that we harbor in our respiratory tract, they do not cause any problem when you are healthy. When you have your innate immunity is present, those organisms cannot harm you. On the contrary, when you become critically ill, and in addition, when you are not able to breathe and you require a ventilatory support, the same organisms which are normally present as common salts, they get virulent or become more in number, and they become pathogenic. So this is the important change that happens in the ventilator-associated pneumonia. So this biofilm occurs within hours of intubation, and they precede, or this is the first step in the formation of VFB. So the longer the period of mechanical ventilation, the greater the risk for development of ventilator-associated pneumonia. So this is the second step. So the ICU therapies form the first basis for the formation of VAP, And the second step is the changes that happen in the endotracheal tube, allowing the communication through the lungs, bacterial biofilm formation, endotracheal tube cuff which folds along the surface, risk for reduced pressure as well as microaspiration. So these are the three things that you have to remember with the cuff. Now coming to the microbiology and local innate immunity and inflammation, VAP is a polymicrobial. So it is not the single pathogen or the bacteria which normally causes this VAP. There are multiple organisms. Among them, one may become dominant. So it is a polymicrobial, antibiotic resistant type of bacteria may be there. And the most prevalent organisms are gram-negative bacteria like Klebsiella, Acinetobacter, Pseudomonas, Escherichia, and Enterobacteria. And some gram-positive bacteria species like Staph aureus and Enterococci also can be there. Very rarely, if the patient has very low immunity or if he is an immunocompromised patient, they can develop a fungal colonization also. Candida colonization is common for causing what is known as fungal VAP. So mostly it will be bacterial ventilator associated pneumonia, but in patients who are severely immunocompromised, it can become a fungal VAP also. And based on the bacterial data, bacteriological data, it can be classified as early onset and late onset. So early onset means bacteria start developing, multiplying very fast and produce all the features of pneumonia. And if it is an early onset, the advantage, as Dr. Anjali mentioned, is it is easily curable because it will be very susceptible to the antibiotic that you give. Whereas if it happens quite late after say 4 days or 5 days after intubation and ventilation, which is called the late onset pneumonia, they happen because the organisms which grow in that condition, they are more resistant to antibiotic therapy, and the late onset pneumonia usually carries a very poor prognosis. So early onset VAP caused by bacteria which are antibiotic sensitive, like strep pneumonia and enteric gram, and has a better prognosis, whereas late onset VAP caused by multi-drug resistant pathogens and they have higher morbidity and mortality. So that is the reason why this classification is important. However, the timing of onset is not only the risk for multi-drug resistance, but also the other factors which determine the severity or mortality and morbidity are the pre-admission immunosuppression. For example, patients who undergo transplantation and those who are given immunosuppression to prevent organ rejection, and if they are put on ventilator, they have higher chances of developing ventilator associated pneumonia because their overall immunity is suppressed, and these organisms will become more resistant to any antibiotic and they have a poor prognosis. And if already some antibiotic, high spectrum antibiotics has been used, or they have undergone hospitalization and have been exposed to the other strains in the hospital, they have the risk of multi-drug resistance. So three reasons for developing resistance is immunosuppression, prior antibiotic use, or exposure to hospital environment leading to exposure to the hospital pathogens. So these things cause the patient to develop multi-drug resistance pneumonia. And in patients with bacterial pneumonia, reactivation of cytomegalovirus or herpes simplex or Epstein-Barr virus, so all these viral things can be stimulated or reactivated, which can also be present along with the bacterial type. And the lung was considered as a very sterile zone earlier, but now it has been recognized they have a diverse and dynamic microbiome. That is, as I told you, they harbor organisms in every one of us. One of the surgery professor who was working in Stanley, in those days we had what is called honorary professors who are not in the regular paid role of surgeons or physicians. They were called honorary professors who worked for their passion to teach, and they were good surgeons. So government employed them without giving them a regular salary. They used to come and work in the hospital. So one such person, Professor Rajshekhar Reddy, his name was, he always used to ask a question to the students: which is more contaminated, oral cavity or vagina? And invariably, everybody thinks the vagina harbors more infective organism, but you will say your oral cavity has more bacteria than the vaginal cavity. So that is the reason these bacteria can grow when your immunity goes down. That is why we also develop the respiratory tract infections, because at times when our immunity goes down, these organisms will take the upper hand and start giving you the problem of a cough or respiratory infection and all those things. So the main symbiotic ecosystem and immune homeostasis is altered in these patients when you intubate and ventilate them. So numerous factors cause this microbiome dysbiosis. When you say symbiosis, all of you know that uh, existing with harmony, that is symbiosis. But when it becomes dysbiosis, existing with fight between one another, that it becomes a dysbiosis that happens during critical illness, prior antibiotic use, mechanical ventilation or diet changes, and get exacerbated and cause the complication of ventilator associated pneumonia. And dysbiosis of the lung microbiota, that is the organisms in the lung, are linked to either the oropharyngeal microbes that are present or translocation to the lungs via the ET tube from the oropharynx. Okay, so just like the where else you use this word translocation? Have you heard of this important terminology called translocation?
In genetics, sir.
Genetic, not genetic. Why do you want to feed a patient as early as possible? Why enteral feeding is considered more appropriate than parenteral or intravenous therapy?
It protects the gut bacteria, sir.
That is again that's called the gut bacterial translocation into the systemic circulation to produce septicemia. Okay, so that is the reason why if you keep feeding the patient enterally in the normal route, you will protect or retain the gut bacteria, the commensal there. If you don't have food in the gut or in the intestinal tract, these bacteria are itching to go somewhere, and they get entered the blood circulation and become translocated to the systemic circulation to produce systemic septicemia. Okay. Similarly, the oropharyngeal secretions which harbor the organisms, they can go into the lungs via the ET tube alongside the gut to translocate to cause the ventilator associated pneumonia. Okay, so that's the reason why I have been comparing the activity of the gut or the intestinal tract to the lung. I mean, there are so many similarities here. Now, another important pathological change that all of you have to remember is the innate immune response on the lung parenchyma. Okay? For pneumonia to develop, bacteria must first overcome mechanical barriers such as cough, swallowing, and mucociliary accelerator. These are the three normal protective mechanisms where we prevent the bacteria going down the respiratory passage up to the alveoli, where it has to cause all the problems. So in a normal healthy individual, we do cough, we swallow the secretions, and we have the well-functioning mucociliary escalator, which will prevent the translocation of the bacteria from the oropharyngeal cavity into the lower respiratory tract. So this is when that is affected. When these three barriers are not working properly, then the secretions or the bacteria get translocated from tracheal to lung, and they exceed the lungs' capacity to maintain the immune resistance and tissue resilience. So that is why I told you the common existing organisms, they become more powerful when your lung innate immunity is affected. Here comes the role of alveolar macrophages, which are diverse phagocytic group in the lower respiratory tract. So nature has given us a protection in case the bacteria migrate from the oropharynx and the upper airway down to the lower airway. Alveolar macrophages are the soldiers waiting there to protect our lung without going in for the pneumotic changes. And these alveolar macrophages have the capacity to do phagocytosis. That is, they can engulf bacteria and kill them and protect our lower respiratory tract. So under healthy conditions, these alveolar macrophages maintain alveolar homeostasis and the most abundant innate immune cells. And they are the immune cells which protect us lower respiratory tract, and they provide the first line of defense against any invading respiratory pathogen. And these macrophages adapt to provide phagocytosis and apoptosis of the microbes. So the bacteria will be killed by these macrophages, and they coordinate the innate immune response of cytokine activity through the nuclear action, KB, transcription, and all these cytokines, you know, interleukin 1, B, C, all these things are the cytokines which are stimulated and that recruit neutrophils to the site of infection. So they bring their soldiers from the blood into that arena of bacterial invasion and try to eliminate that. So the first line is macrophages. The second line is recruitment of neutrophils from the blood by stimulation of the cytokines. This is the second mechanism by which we are all protected from developing a pneumonia every day, because bacteria keep entering our lower respiratory tract on and off. And these macrophages act as antigen presenting cells also and trigger cellular and humoral responses, but they also lead to inflammation of the lung parenchyma. If they are not adequately present, then only these changes will happen and capillaries will start leaking and there will be exudative congestion. This is the stage where you actually start developing the pneumonic changes. So when pathogenic microbes overwhelm the local immune defenses, so the enemy becomes more stronger to invade and then try to attack our immune or defense system. The macrophages and epithelial cells they try to release additional cytokines so that more neutrophils will be brought into the air spaces. And the positive bacterial culture, there is recruitment of neutrophils to the lungs, resulting in phagocytosis, degranulation, and release of oxygen, reactive oxygen species, and formation of the so-called neutrophil extracellular traps. This is called NETs. And these NETs, they contain a substance called histones and antimicrobial peptides, which can kill invading pathogen associated. So these are all the natural mechanisms of protection. And in patients who are critically ill and who are being ventilated, all these innate mechanisms, that is why this innate immune response is totally lost and the lung parenchyma is going to be affected. Now, once you lose your innate immune response, what are the changes that happen? There's a localized inflammation caused by the VAP, pulmonary cytokine upregulation termed biotrauma. So there are 4 types of trauma in the lung that all of you would have heard. Can you tell me or enumerate what are the 4 types of trauma, Anjani?
Sir, what's biotrauma?
Biotrauma I have given here. That is the last. What is the common, a more common type of trauma that can happen to the lung if you are mechanically ventilating a patient? Anybody else?
Apart from that, sir,
Barotrauma.
Volutroma, barotrauma. Barotrauma is the most commonest. When you keep P for a positive pressure in a mechanical ventilated patient, the most common trauma is barotrauma. High pressure causing rupture of alveoli, leak of air, producing pneumothorax. That is the commonest type of trauma that can be inflicted iatrogenically. That is barotrauma. And when you give high volume, low respiratory rate ventilation, it can cause volutrauma, or there may be a entrapment of air, and especially in COPD patients, if you are going to ventilate them, there will be incomplete exhalation of the gases leading to gradual entrapment and emphysematous changes happening, leading to volutrauma, increase in the volume. Then there is a thing called atelectatic trauma, where alternate collapse and expansion of a particular part of the lung that may damage the alveoli. That's called atelectatic. And the last one is the biotrauma, where the pulmonary cytokine upregulation happens. So 4 traumas you must remember: barotrauma, polytrauma, atelectatic trauma, and biotrauma. Okay? So although neutrophils play an important role, the release of NETs, which I told you, neutrophil stimulated traps, can contribute to localized and persistent inflammation, and the persistent inflammation can lead to lung injury and increase the risk of mortality. So histologically, there will be consolidation with leukocyte accumulation in the bronchiole and alveoli, and VAS has been categorized into 4 stages. So the changes that take place, the types we saw earlier as early onset and late onset based on the occurrence of duration immediately after intubation and ventilation. If the patient shows features of pneumonia, that is called early onset pneumonia. If it happens after 4 or 5 days, it is called late onset. But histologically, what changes happen, they are graded into 4 stages. So the early stage is the bronchiolitis characterized by purulent mucus secretion. Then proliferation of polymorphonuclear lymphocytes will be there within the bronchioles and bronchiolar wall. Then there will be focal bronchopneumonia, and there will be scattered neutrophilic infiltration in the terminal bronchioles and alveoli. Then what will happen? These bronchopneumonia segments will coalesce. Many number of the small segments will coalesce and form into, extend into the adjacent lobe. And finally, that is the stage when it spreads into multiple lobes. It is called the consolidation stage. Once the consolidation becomes extreme and then it becomes liquefied, then it goes into what is called the lung abscess. So the final step of this pathological change will be from the early stage of infiltration, it will go into the final stage of lung abscess formation. Okay? So this picture, this is the third thing to show the immune response. This is the healthy alveolus, where you have the alveoli lined with type 1, type 2 pneumocytes, and alveolar macrophages are always there to protect it. And you have the surfactant production from the type 2 pneumocytes, trying to keep the viscosity and collapse and expansion of the alveoli. And you have the capillaries which have a normal endothelial lining. The RBCs are flowing. Endotheliums have the tight junctions in the capillary. But once the inflammatory process sets in, what happens? The bacteria which are coming in are first attacked by the macrophages. So they try to control the infection by phagocytosis and the apoptosis of the bacteria. Then the type 2 pneumocytes, they try to react, and the neutrophils from the blood, they enter the alveoli, and they also come and try to attack the bacteria and prevent the further spread or colonization of the bacteria. But when these innate mechanisms are not adequate or not sufficient in patients who have a compromised immune system, then the bacteria become overwhelmed and they start affecting, and they come into the interstitial space. You can see the space is getting edematous because fluid is going down. Here you can see the gap is narrow between the alveoli and the capillary, whereas here the capillaries have been pushed away and there is a gap and fluid starts collecting in this, and that is the one which is going to prevent the transfer of gases. Oxygen cannot enter, but carbon dioxide will dissolve and enter, and initially it will have a normocarbic hypoxemia. Later on it will become hypoxic hypercarbia also. So this is a non-homogeneous diffuse process where involving both lungs and the mainly the lower lobes will be affected. And this pattern of distribution of the bacteria from central to distal is mainly because of the flow of air by the mechanical ventilation. So this much you have to know about the pathological and histological nature of how the VAP affects the alveolar level and produces the mnemonic changes. Now coming to the diagnosis, when will you suspect that the patient is developing VAP once they are on a mechanical ventilation? The clinical criteria, as we said, is the fever. Of course, the patient with a tube cannot cough, but they will have a repeated coughing tendency. So if you are not paralyzed or sedated, they will be trying to clear the secretions when they have good muscle power. And we think he is fighting the ventilator, and we try to paralyze and sedate them and worsen the condition. Okay, so this is what you have to know, that in the early stages, if the patient is not tolerating it, it is not merely fighting, it may be the early onset of VAP. So that is the thing that we have to understand. And the respiratory rate, innate respiratory rate or the native respiratory rate will go up. So you can differentiate easily. The patient's spontaneous respiratory effect is between 12 and 18, then definitely it cannot be VAP. On the contrary, if his native respiratory rate goes beyond 24, that means that he is developing tachypnea, which is an indication of the VAP. And he starts desaturating, and you will get a sputum which was watery initially will start becoming thick and purulent and tenacious. Radiological investigations which may help are chest X-ray, which will, of course, all of you know how to identify a consolidation in the chest X-ray, and sometimes the CT chest will also have to be done, which will tell you the exact location of the changes that are happening. Lung ultrasound is being increasingly used nowadays for identifying any lung pathology, and we can find this by the because it's a non-radiation hazard equipment, and it's a point of care availability is there. You need not ship the patient and transport them, and it is non-invasive. So all these advantages are there in the lung ultrasound, and you can detect the subpleural consolidation or by dynamic bronchogram features, because the lung ultrasound, the pictures of consolidation and the A line, B line, all these things are OSCE and the questions that will be kept in the OSCE papers. And visualization can be challenging in patients who are obese or who have lot of edema. So subcutaneous emphysema or chest wall edema, you cannot use ultrasound successfully to identify consolidation. Then comes the important culture and sensitivity of the sputum to identify the type of organism. Then microbial diagnosis can be done using endotracheal tube aspirates. So you use a sterile catheter and aspirate the lung secretions and transfer it to the culture tube and send it for culture analysis. Or in the lower down infections which are seen at the lower lobe level, you can do a bronchoalveolar lavage. And but the bronchoalveolar lavage is usually an invasive technique using a fiber optic bronchoscope. But you can do two things there. One is the BAL, another is called the protective specimen brushing, PSB. So both are these two things happen because the upper airway contamination is bypassed. So if in the endotracheal aspirate, it may be aspirated from the upper airway. So you may not get a clear real picture of what is happening in the lower airway. but this BAL and PSB give you the exact growth of bacteria from the lower respiratory tract. And qualitative and quantitative microbial analysis is also important. Apart from identifying what is the exact bacteria or organism growing, you must also find out the colony count. What is the colony count? So the more the number of colonies growing, that means the infection is very severe. And this is important to decide about the dosage and the duration of your antibiotic therapy. So qualitatively, you just find out what exactly the organism is. Quantitative, you analyze by the colony count and decide about the rationale for quantitative cultures are the respiratory section sample from the patients is to differentiate the infecting organism as well as to optimize the antibiotic therapy. So you have to do both qualitative and quantitative microbial analysis. And system called clinical pulmonary infection score system, which was developed to diagnose as a diagnostic tool as well as the prognostic tool. So this CPIS, clinical pulmonary infection score, is a very important scoring system. It gives a score of 0 to 1 for these parameters: temperature, leukocyte count, PaO2 FaO2 ratio, chest radiograph, and the culture tracheal aspirate. All these things are taken into account, and the maximum score can be obtained is 12, and any score of more than 6 is considered as to be diagnostic of ventilatory assisted pneumonia. Now coming to the VAP prevention, there are two bundles which are used. What is a care bundle? What is the definition of a care bundle? You all hearing?
Yes, sir.
It is a group of proven interventions. Okay, evidence-based successful interventions are called care bundle. Okay, so all of them have been grouped together. Where do you use this care bundle, or the which other condition you will use this terminology?
In sepsis.
Sepsis.
Central
Okay?
input.
Sepsis. You can use it in sepsis also. Okay, sepsis care bundle. We have the initial bundle and maintenance bundle. Okay, resuscitation bundle and maintenance bundle. So they are nothing but a group of evidence-based successful interventions which have been tried and found to be quite useful, grouped together. Okay, so the daily sedation holds. As I told earlier, whenever we put a patient on ventilator, to prevent them from fighting the ventilator, invariably we sedate them in the initial stages. And as we try to wean them off, we try to reduce the sedation so that their spontaneous respiratory activity is encouraged, and we can slowly wean them off and disconnect them from ventilator and extubate them. So this daily sedation holds or interruptions in the sedation, bedhead elevation, gastric ulcer prophylaxis, and oral care. These were the 4 things which were considered as important in 2007. Then it was updated in 2010 to include oral hygiene, not merely by suctioning and brushing, but also with adequate antiseptics like chlorhexidine. Then subglottic aspiration of the collection, CT tube cup pressure monitoring were also added to these 4 things. Then bacterial colonization, biofilm formation on the inner surface, which can be prevented by coating it with a thin layer of antimicrobial agents. So nowadays we have TT endotracheal tubes which have a antibiotic coating. So these type of tubes are more recommended for patients who have already compromised immunity, like patients who are undergone onco surgeries, patients who have undergone transplant surgeries, or patients who are suffering from human HIV virus infection. So all these immunocompromised people, it is better to put this endotracheal tube at the time of intubation itself with the antimicrobial agents. and they have tried gentamicin nebulization, antibiotic nebulization by aerosol, so that the local action will be there to control instead of the parenteral antibiotics. So many things they have been trying. So, but you have to mention these two important care bundles that have been used. And coming to the management, he mentioned so many antibiotics are used. I am not going to give all the details, but what you have to know is first you can start them on an empirical antibiotic cover. Whenever patient shows signs of VAP like increasing fever, leukocytosis, purulent discharge. So before you confirm what exactly the organism, we cannot wait for 48 hours for the culture result to come. So we always start the patient on an empirical antibiotic with a broad spectrum, and which will cover all these both gram negative and some gram positive. And then once the culture comes and the specific sensitivity is known, then you start them on that particular narrowed down the spectrum of antibiotic and treat them for a minimum of 5 to 7 days and longer if required, depending upon the colony count and the chest and the radiological, clinical and radiological findings. Okay. So this is considered as the algorithm for patients who are on mechanical ventilation. So first step is see whether there is a deterioration in the respiratory tract and whether there is activation, and suspect VAP and calculate the clinical pulmonary infection score. So immediately after, once you suspect VAP, to confirm the diagnosis, you go for the CPS scoring. Score more than 6 with the data available, commence antibiotic therapy. Score less than 6, complete other investigations. Then sputum sample, chest imaging, signs of VAP, again go for antibiotics. So ultimately, the antibiotics is the sheet anchor of the correction of this particular condition. But how much, how long, is all dependent on the culture and the sensitivity. And is there a role of artificial intelligence in VAP? Nowadays, we talk about artificial intelligence in all forms of medicine. So is there a role for artificial intelligence in VAP? With increased availability of electronic health records, artificial intelligence can process and interpret vast and complex data and opportunistic disease identification, outcome prediction, and phenotyping within the field of VAP also. Now, AI uses supervised, semi-supervised, and unsupervised machine learning to interpret complex information, confounding variables, and pre-existing conditions to support the diagnosis and disease identification. Okay? And AI can potentially expedite and enhance CT or CXR interpretation and aid in decision making without microbial sampling. This is a very, very important point. So once if this comes into our routine practice, we need not unnecessarily wait for 48 to 72 hours to culture the sputum and get the sensitivity, what is the organism grown. All this can be avoided, and treatment, the correct treatment can be initiated as early as the first 24 hours of identification of VAP if this facility of AI comes into real practice. Okay, so these are all the things I want to share with you. So any doubts or any questions?